Bismillahirrahmanirrahim. Assalamu alaikum. How are you, student? I hope you are doing well in this COVID environment. Last time we have discussed clinical feature, presentation, examination findings, investigations, and differential diagnosis of cholelithiasis, cholecystitis. Today is a short lecture on treatment of cholecystitis and cholelithiasis. Now, acute cholestasis is usually treated with conservative management, and in 95% cases they resolve. The inflammation resolves and patient feels better. Now, this is called conservative treatment or non-operative treatment. It consists of the following principle: that patient should be nil per orally, because due to inflammation there is nausea, there is some stresses, anorexia, and if you push patient for feeding, so there are chances of vomiting. So better avoid uh, oral food for a few days and start patient on IV fluids, so that patient does not dehydrates. Analgesics or painkillers are advisable, and antibiotics should be given. Now, a patient, this is called empirical treatment. The patient with cholecystitis are usually having some gram-negative organism. So these cefuroxime and ciprofloxacin, these drugs are effective in that condition. And once the inflammation subsides, we can then book that patient for cholecystectomy. Now, nowadays they say that if patient is admitted in the ward, start with this treatment, and on the next available list, mean that within the next 2 to 3 days you can operate that patient. Or other option is that wait for inflammation to subside and then operate after a week or two. Now, there are one indication, as you saw just now, that one indication of cholecystectomy is cholecystitis, and which does not respond, the cholecystitis which does not respond to medication. Now, there are some other indication for cholecystectomy. Now, cholelithiasis is an indication if patient is symptomatic. Uh, Otherwise, there is no need to do cholecystectomy, but there are risks involved, because when patient comes to us, the patient says, okay, there is no symptom, but the stones have been diagnosed incidentally. Incidentally mean that just they went for ultrasound, and ultrasound detected some stones. So when we counsel patient, there is no need of surgery if you do not have symptoms. But once the patient have stones in the gallbladder, so they have a psychological effect. They come again and again that we have pain in that area. So in our setup, in our culture, if there are stones and patient persists for operation, so you go for operation. Another reason for operating this patient, that there are chances of complication. Complication of cholelithiasis. What are those? Those are mucocele formation, empyema of the gallbladder, and perforation. They can occur at any time if there is some stone stuck at the cystic duct. And third reason for operating this patient is that as the age advances, the patient may develop some cardiac problems, some other chest problem, due to which then they are not fit for surgery. So it is better to operate when they are fit. So we're coming to other indications of cholecystectomy. Now so far you have understood two indication of cholecystectomy. One is cholecystitis, and second is cholelithiasis, and especially symptomatic cholelithiasis. Now, cholecystosis is a group of conditions in which there is chronic inflammation with hyperplasia of all layers of the gallbladder. These conditions are cholestyrosis, polyposis, adenomatosis, and cholecystis glandularis, proliferance of the gallbladder. We'll discuss briefly one by one. Cholestyrosis is a strawberry-like strawberry looking gallbladder, and it is mainly due to cholesterol particles, small crystals of cholesterol in the wall, and these patients should be operated for this condition. Cholesterol polyposis. Sometimes there are polyps in the gallbladder. Now, how you will differentiate polyp from the stone? Stone gives shadow, and these polyps do not give shadows. You can see these small polyps in the gallbladder wall, and they remain stable at that area. Now, why we should operate this patient? Because on ultrasound we cannot differentiate whether this polyp is a simple polyp or it is in adenomatous polyps, because adenomatous polyps can give rise to carcinoma of the gallbladder and can spread, because there is gallbladder is just abutting the liver, so there are chances of spread of the tumor. So better to operate if a patient is diagnosed as polyp of the gallbladder. Another condition is cholecystitis glandularis proliferans. These are again different conditions. You can see there is this is a polyp, and then there is a adenomatous intraluminal diverticulum. This is polyp, and this is intraluminal diverticulum outpouching. And sometimes this outpouching can give rise to fistula formation. And then when there is outpouching, and there is stasis occurs in that area, and you can see stone formation. So these, due to proliferation of glands, due to enlargement of those ducts, give rise to multiple conditions, and therefore they should be operated because they are very much prone to develop complications of perforation and empyema. Another condition is multiple diverticula of the gallbladder. You can see there are multiple white patches. There are many, this lacuna of Luschka outpouch outside and can give rise to multiple diverticulum. And then diverticulum, again, those are things that stresses infection and mm, sepsis. So therefore, better to operate if ultrasound report is diverticulosis of the gallbladder. Typhoid infection of the gallbladder. This salmonella typhi is the residence area of the salmonella typhi is gallbladder, and the stone was previously known as the tomb of salmonella typhi. So the patient may not be having any symptom, but it may be carrier. So when you do tests for those patients and they show that there is typhoid test is positive for those patients, so better to operate because they are carrier and they are spreading this typhoid. Usually, this test is done for the people who are working in hotel kitchens, and they, if found typhoid carrier, so they are advised to undergo cholecystectomy. So, if we summarize indications for cholecystectomy, so far there is cholecystitis, acute or chronic. Now, why to operate for cholecystitis? Because although inflammation subsides, but once inflammation occurs, gallbladder loses its function because there is it does not the normal function of absorption is lost. So cholecystitis, cholelithiasis, symptomatic cholelithiasis, and cholecystosis, which consists of cholecystosis, glandularis proliferans, polyposis, and diverticulosis of the gallbladder. So these were the different reasons to operate. Now, how you prepare patient for the cholecystectomy? We have already discussed previous investigation. Again, I will just repeat that you divide investigation in three groups to confirm your diagnosis, to know the extent of the disease, and to know the fitness. So full blood count will show again as hemoglobin level and if there's any infection is present. Renal profile and liver function test again show us fitness and extent. Now, liver function test shows us extent of disease, whether there is hepatitis with it or not, and whether the liver is functioning properly or otherwise. And renal function are very much important for the patient to undergo anesthesia because the patient does not recover from a compromised renal function. So you are creating much more problem than benefit. Prothrombin time in those patients in which there is history of coagulopathies or there is history of uncontrolled bleeding, so you can proceed with prothrombin time. Every patient does not need this test. X-ray chest and ECG again for fitness. And antibiotic prophylaxis should be given every any patient before surgery, and should be within 1 hour or within 6 hours of the of booked surgery. You should give antibiotic. A deep vein thrombosis prophylaxis again, it is a different topic. There are different methods of deep vein prophylaxis. We do not usually give a deep vein prophylaxis, but if a patient is very obese, so you can do prophylaxis with some anticoagulant like Clexane, etc. And informed consent is very much important. Now, how you operate? I will not give in much detail for you. It's not for you. So, but you should know some few things that if somebody asks you that, okay, you will do cholecystectomy, so how you will do it, or where is the incision? So at least you know the incision name and where it is. So this is Cocker incision, and this is start from the almost midline and up to the tip of the ninth costal cartilage. So it's parallel subcostal incision. Now, what structure are cut in this incision? This question may be asked from you if examiners want to give you some more marks to know that how much you know. So this is anatomy. You should recall your anatomy, that there is skin, there is subcutaneous tissue, then there is uh, rectus sheath beneath this skin, and then behind rectus sheath there are up to this area there are rectus muscle, recti on the midline, both sides of the midline. So there will be recti come in your incision, and on the lateral side there will be transversus abdominis muscle will be there. And when you cut this, then there those muscles, then there will be fascia transversalis and peritoneum, and then you reach to the gallbladder. So I will repeat again that the structure you will cut and to reach gallbladder, Cocker incision. You make a Cocker incision from the midline up to ninth costal cartilage, about 2 centimeter below the costal margin on the right side, and you will go through subcutaneous tissue, rectus sheath, rectus muscle, and transversus abdominis muscle, posterior rectus sheath, fascia transversalis, and then there is peritoneum. Now, there are two methods of cholecystectomy. You may be asked that what is this? This is open cholecystectomy, Cocker incision, and then you can do laparoscopic cholecystectomy. So, how you will answer this question? The examiner may ask you which one is better. So, answer should be better is laparoscopic cholecystectomy, but if expertise are available. So your answer should be that if expertise are available, laparoscopic cholecystectomy will be planned. Now in laparoscopic cholecystectomy, what do? You make small incision and small holes, and then you go in through camera. Now this is subumbilical incision about 1 centimeter or 12 and this is called umbilical port is called camera port, and then there is epigastric port through which is working port, but you should know just that there are umbilicus port, epigastric port, and two small on the right side, one at uh, mid-clavicular line and other is right anterior axillary line. You can see there are four ports for the laparoscopic cholecystectomy, and then you do laparoscopic cholecystectomy. Now, what are the benefits of laparoscopic cholecystectomy? Now, benefits are there is less trauma, early recovery, early joining of the business, whatever business patients has. So these are the main benefits of laparoscopic cholecystectomy. And obviously, cosmetically, if you look at this scar, and this scar, okay, whatever procedure you adopt, whether laparoscopic or open cholecystectomy, ultimately the rest of the principle are same. When you reach to the gallbladder, you identify what you do, you dissect and you identify the Calais triangle we have discussed last time. And what you find in Calais triangle, there is lymph node of Londe and there is cystic artery. So the purpose of the main step are that you ligate, you identify. First thing, whenever you are asked about steps of procedure, you will not be asked, first you may be asked a few common steps like appendix and this gallbladder. So important steps are to identify the structure which you will cut. So to identify the gallbladder, and then cystic duct. Now you can see cystic duct is joining the common hepatic duct and making further CBD. So you identify that you do not ligate this common hepatic duct. It happens to many experienced surgeons that this sometimes do not identify clearly, and then may ligate and cut. And you ligate, cut, and cut here, so this will lead to biliary injury. There will be bile leak, and that is disastrous. Similarly, if you do not identify the cystic artery, what will happen? You can cut right hepatic artery, or you can cut main hepatic artery, and that will be disastrous. There will be a lot of bleeding. So identify cystic artery. How you identify? You will, when you do dissection, you will see the two structures are entering into the gallbladder. Now this cystic duct is very tricky. Sometimes it is just zero point 0.5 mm. Sometimes it is dilated as the gallbladder. So you will see the two structure entering the gallbladder. One is this artery, is the cystic artery, and then you cystic duct. So first identify the structure and then ligate. And after ligation, then you cut. When you cut, you slowly and gradually remove it from the bed by securing bleeding, securing hemostasis. Now, what complication can occur during this procedure? There are acute and there are chronic. What are acute? Anesthesia-related patients, make go into cardiac arrest, can go into shock due to anesthesia medicine, and surgical. It may lead to bleeding, and three reasons of bleeding, three types of bleeding: reactionary and immediate, reactionary and late, delayed bleeding. And their patient may be having after recovery pain. So if you do not have given optimal anesthesia during surgery, so patient will have more pain. So therefore it's very important that you should control pain during and after surgery. Biliary injuries I have discussed with you, and vascular injuries, and similarly gut injuries. You see here, when you open, this is which part of the gut? This is duodenum. This CBD is going into duodenum. So here duodenum can be damaged. Now here is the hepatic flexure of the colon that can be damaged if you do not retract it properly and cover it with the gauze. So gut injuries can occur. And then there are chronic complication, which is one is post-cholecystectomy syndrome. Now, post-cholecystectomy syndrome means that the same symptom of epigastric pain and flatulence and dyspepsia persist even after surgery. So the reason, then you look for those reasons. Reason maybe there is maybe some stone in the bile duct, a stone in the cystic duct stump, or operative damage to the biliary tree. I will go again to that picture. Sorry. Now, if you damage that, if you tie it very close to the system, to the CBD, so there may be some wall of the CBD is lost and it become tight, so it may lead to stricture. Sometimes there are difficult gallbladder and there are small stone. You ligate from here, and there is some stone may remain here in the stump. This is called cystic duct stump. So in this stump, some stone can remain. So you investigate those patient for these thing. If there is nothing like that, if the biliary tree is normal, if there is no cystic operative stone, stump stone, so then the reason may be gastritis. It's very important to counsel patient before surgery that look, this pain, which you call it epigastric discomfort, dyspepsia, this pain may persist even after surgery, because if you do not counsel, patient will be feeling bad, their surgery was having no benefit. So therefore, uh, counsel patient before surgery that your symptom may be due to stomach problem, gastritis or ulcer. Ulcer you will diagnose on endoscopy, but gastritis, there may be mild gastritis, which for some patient will present with significant symptoms. So then patient may ask you that, okay, if I persist those symptoms after surgery, why I should be operated? So benefit of operation is, if patient does not operate this, we do not know whether this is due to gallbladder or it is due to stomach. But if you do not operate, the gallbladder complication, which we have discussed so many times, there is risk of development of those symptoms. So benefit of surgery is that, okay, you may or may not have this epigastric discomfort or flatulence, but it will be clear that you do not have gallbladder, because gallbladder we have removed with surgery, and you are free of the complication or that fear that what will happen. So if patient having mild gastritis, mild gastric pain, so that should be treated with the antacids, omeprazole, etc., and H2 blockers, PPIs, proton pump inhibitors, and you should always again look for the cardiac problem, because epigastric pain, I told you before, that very tricky. Patient may have epigastric pain and patient may have actually a cardiac problem. So exclude those things. When those are excluded, then you are relaxed and you can give just gastric medication. And how you can confirm that there is no cholecystectomy syndrome? By going, if ultrasound does not show, you go for MRCP. If it does not if it shows something like the stone is in the CBD, so then you can proceed with ERCP. I hope the complications are clear to you. So this was all about this lecture today, that we have discussed indications of cholecystectomy and different complications, and a little bit about procedure. If you have any question about this, you can contact me and you can give feedback. Thank you very much and have a good day. Allah Hafiz.